Uh, the final session will be debate, and I would like to introduce Dr. Awadh Kishor Pandit, Assistant Professor, Department of Neurology, AIIMS, New Delhi. Sir has previously worked as an Assistant Professor of Neurology in PGI Chandigarh in 2015 to 16 with 30 publications and various abstracts in field of stroke and air pollution. His area of interest being acute stroke and prevention of stroke and neuroendovascular therapy. Sir will be moderating the session, and participating senior residents for today's topic, that is low NIHSS with M1 occlusion, to intervene or not. Dr. Akil Sahib, senior resident 5th semester from Department of Neurology, AIIMS, will be speaking for the intervention, and Dr. Shiv Narayan Pattnaik, senior resident 6th semester from PGI Chandigarh, will be speaking against the intervention. The time frame for the session will be 30 minutes. I would like to hand over the session to Dr. Awadh Kishor Pandit, sir.
Hello, Dr.
Yes, sir.
Am I audible?
Yes, sir, you are audible, sir.
Yeah. And first of all, I would like to thank the organizer, course director, specifically Professor Padma ma'am and Dr. Lal. And both have been my teachers. And I also thank the organizing group members, Dr. Annu and Dr. Vishnu, who have done it so precisely, and everything is perfect and nice discussions. So I would like to start this session of low NIHSS with M1 occlusion, intervene or not. So I would suggest that residents should not make their opinion now. Just go through this debate and see what is in favor of it and what is against it. And then we will come to a conclusive conclusion that really we should intervene in these M1 occlusions with presenting with low NIHSS. Overall, the guidelines are still not very clear. It is still a matter of debate. So I would invite Dr. Akhil to start in favor of this topic. So Dr. Akhil, please start.
Thank you very much, sir. I will share my screen now. Thank you so much, sir, for inviting me for this session, and I am indebted to all my teachers for giving me an opportunity to speak in this distinguished panel. I am Dr. Akhil, 5th semester resident, and I will speak in favor of intervention in low NIHSS score with M1 occlusions. As we all know that time is brain, and with each second, minute, and hour lost, especially in an alveolar stroke, there are humongous amounts of neurons, synapses, and myelinated fibers lost, and in turn, which lead to accelerated brain aging. We all know that mild strokes are the most common strokes, as was shown in this landmark epidemiological trial that was published in Stroke in 2013, in which about 2,000 patients, more than 50% of the patients were having mild strokes with NIHSS less than 4. Now, there are inherent fallacies of NIHSS in calculating the outcome in mild strokes. As was shown by this study that was done in 2005, it was a retrospective study in which the patient data were approximately 2,000 patients were included, and retrospectively the retrospective NIHSS was calculated on the basis of the medical records. And in this, we can see that in patients who are having same NIHSS scores like in C, D, and E, they have a wide and different outcomes. This was probably attributed to the factor that in group C, the NIHSS score was low, probably because of loss of consciousness questions and language functions, while in D and E, it was low because of disorder of motor functions, especially on the right side. So not only NIHSS is a poor predictor of outcome in mild strokes, it is also a poor predictor of proximal occlusions. That was shown in this study, in which approximately 1/3 of patients who were having NIHSS less than 6 were harboring a large vessel occlusions. And there was a significant number of these patients with low NIHSS were harboring a M1 occlusion also. So what are the causes of worsening? They can be due to collateral failure or distal occlusions. Now, what happens when the collaterals fail? Now, there is early neurological deterioration. As was shown in this study, in which out of 378 patients, 83 patients showed early neurological and severe early neurological deterioration. And there was an interesting fact that the patients who were harboring ICA and proximal MC occlusions were having more early and severe early neurological deteriorations with odds ratio of 7.2 and 3.03 respectively. So patients with LVO with mild strokes have a propensity to worsen over time. And not only they have an early neurological deterioration, they have a poor outcome at discharge also, as is indicated by MRS score more than 2. In this study, we can see that 50% of patients with large vessel occlusion had a poor outcome in comparison to 13 with no large vessel occlusion, with p-value of 0.04 that was statistically significant. So the mild stroke is not always mild, especially with the large vessel occlusion. In this study conducted by Yasir Salim et al., that was published in Stroke in this year only, out of 122 patients, 40 patients had a neurological deterioration in the form of NIHSS score more than 4 or up to 1 to 3, early neurological deterioration, and there were two factors common. The head-up worsening was only seen in the patients who have neurological deterioration and was not seen in the patient who had no neurological deterioration in mild strokes with LVO. And another was that they had significant perfusion deficit also. So one thing was common, the most common occlusion in these patients was again M1 occlusions. And the patients who deteriorated, approximately out of 40, 19 had received rescue thrombectomy. And those who received rescue thrombectomy were likely to be independent at discharge, 73% versus 38% with significant p-value. Now in this study, we compared, it was a retrospective study that compared EVT versus best medical management in mild strokes with LVO. Out of 118 patients, 30 received EVT and 88 best medical management. And there was a better or a favorable MRS shift at discharge as well as at 3 and 6 months in those patients who received endovascular therapy as compared to the medical management alone, with significant p-value of 0.04. Similar results were shown in this study that was conducted by Nagel et al. That was published in Stroke in 2018. Now, this is a recent study that has been published from China in BMC Neurology in 2020 only. Again, in this patient, the 177 mild stroke patients with LVO with NIHSS less than 9 were taken, and 79 received thrombectomy and 98 were received only best medical management. And the outcome, primary outcome was, favorable outcome was MRS 0 to 1 at 3 months. Now, in this patient, there was a trend towards favorable MRS outcome in those patients who had received best medical management therapy, 58% versus 46%, with a p-value of 0.13 only, but confidence interval was 0.86 to 2.86. So there was a trend towards benefit, although we can, this benefit can be reshown in a larger trial, randomized trial also. They had done a meta-analysis of 3 trials comparing endovascular versus medical management therapy. And in this meta-analysis also, there was a trend towards benefit with a confidence interval of 1.90 with range from 0.74 to 4.88. It was again showing a trend or a benefit towards intervention only. So we need a randomized trial in carefully selected patients. And I think the selection should be based on the criteria of disabling strokes, patients who have head-up test positive, who have a fluctuating NIHSS score, and who have a large perfusion deficit. Because we need to open the vessels in these patients. As we have already seen, there is early neurological deterioration, especially in mild strokes, and we cannot ignore these mild stroke patients. So mild stroke patients with LVO are rarely not mild at all, and we need some thrombectomy to treat them. Thank you so much.
Yeah, I think now I would invite Dr. Shiv to speak against the notion of intervening mild stroke with M1 occlusion. Dr. Shiv, please.
Sir, good evening, all.
Yeah.
So my topic is, if a patient comes with low NIHSS with large vessel occlusion, it is better not to intervene, not to go for mechanical thrombectomy, rather to go for medical management. So before going to the main topic, we need to address few questions. The first one is the incidence of the acute stroke with the low NIHSS with large vessel occlusion. How common it is? In the out of total number of large vessel occlusion, around 30% comes with low NIHSS with stroke. And how the LVOs can be associated with low NIHSS? there are cases when it presents in the non-dominant cortex, or when it is associated with good collaterals, then it may be associated with low NIHSS, or in a case of early presentation, it can be associated with low NIHSS score. And whether it is relevant to stress upon the section, yes, definitely. If the thing is in the early part of the presentation, if we are going to intervene with mechanical thrombectomy and we are putting some new side effect to the patient, and patient is worsening further, then it is a matter of concern. And even it may improve spontaneously, or it may worsen in the due course of the time. What is the NIHSS level we usually accept as a case of minor stroke? Usually, most of the study accept NIHSS score of 5 as a minor stroke, but this NIHSS level varies from study to study. And the present guideline and research on it till now, the present guideline of AHA guideline 2018 and 2019 modification, they have told that we should not intervene with mechanical thrombectomy if the NIHSS score is less than 6. And we have to also take care of the thrombectomy safety and feasibility part also. So everything is based on the risk benefit analysis. So the main thing is that the Hermes collaboration, that was the primary basis of the mechanical thrombectomy in the stroke patient. In that, very low number of patients were enrolled with NIHSS score of less than 10, and there was no significant benefit in the EVT thrombectomy group, in that group. And in here also we can see that in NIHSS score of less than 10, there was 177 participants were there, and in that it was crossing the vertical line, and it was showing the non-significant part with adjusted odds ratio of 1.67. Here is the AHS guideline, which clearly tells that NIHSS score could be more than 6 before we go think of any mechanical thrombectomy, and before we consider any other part. Coming to some meta-analysis done by recent studies, one of the meta-analysis and systematic review done by the Nitin Goel, where they have taken 251 consecutive cases with low NIHSS and large vessel occlusion. Out of that, 138 cases were made for the mechanical thrombectomy and 113 for best medical management. And they have made the outcome on the basis of functional outcome and favorable functional outcome. In that, what they have shown that the functional outcome is better on the medical side as compared to the mechanical thrombectomy side, and the incidence of the ICH is more on the mechanical thrombectomy side, and which is significantly higher. So it may moreover support the case more towards the best medical management as compared to the mechanical thrombectomy side. They have also considered other studies into the account with Nagel et al., Seres et al., and Ura et al., where they have told that best medical management is much better as compared to mechanical thrombectomy side, as there was no significant difference between the functional outcome, and moreover the symptomatic ICH is more on the mechanical thrombectomy side. So critical appraising of the same study, that is telling that the review address focus the clinical question. Yes, most of the studies have focused on the clinical question. Studies are comprehensive or well documented. Mostly the studies are well documented, and they have high methodological quality or not. Actually, they have not taken sufficient number of patients. It was not randomized control trial. Still, it was telling that best medical management is much better as compared to mechanical thrombectomy. And coming to the result assessment, on the basis of overall result of the study, there was similar outcome in the mechanical thrombectomy trial as compared to the best medical management, except that high spontaneous ICS was more common in the mechanical thrombectomy trial. And either clinical relevant is relevant to my practice. Yes, in the tertiary care, it is applicable to my practice, but it is difficult to apply in the primary healthcare. Coming to the similar type of meta-analysis done in China recently, but they have taken 581 patients and they have shown that the factors supporting mechanical thrombectomy and the best medical management, it is not statistically significant, but there is definite history of more mortality in case of more ICS in case of mechanical thrombectomy trial. So we are giving more morbidity to the patient by doing mechanical thrombectomy, who is going to happen, going to heal by itself or with thrombolysis or with medical management. So other influencing retrospective trial, those are also this is a study done in 2014 by Urax et al, where they have told that MR score at 3 months, it is nearly comparable between the mechanical thrombectomy trial and base medical management, even though there was successful recanalization between the in the mechanical thrombectomy trial, but it did not translate into the better outcome at the 3 months in course. But the significant ICS was there in thrombectomy part. It was 11.8% as compared to the best medical management. So we have to consider both into account before considering mechanical thrombectomy versus best medical management. Here it is shown that best medical management is much better as compared to endovascular thrombectomy trial, and it is telling that even favorable outcome and excellent outcome both are better in the medical management group when the NIHS is low, that is less than 5. According to Siraj et al, also they have told that the excellent outcome between the end thrombectomy trial and between the best medical management, it is adjusted, the odds ratio is 1.3, and functional outcome, independent functional outcome, MRI 0 to 2, it is adjusted odds ratio is 0.9. That shows that there is no significant benefit of endovascular thrombectomy after doing after presentation as compared to the best medical management. So it is best to go for the best medical management as compared to the mechanical thrombectomy. This is also telling that there is when we compare excellent outcome between endovascular thrombectomy and medical management, there is nearly no significant p-value. The p-value is 0.87, and the independent outcome that is also in a non-significant. But as compared to symptomatic hemorrhage, it is more in the endovascular thrombectomy trial. This center also, this is a retrospective study as told by Dr. Akhil. It was also telling that there was better NIHS shift in the endovascular thrombectomy trial, but there was no significant statistical difference in the 90 days outcome. So even though there is immediate betterment in the case of endovascular thrombectomy, but on long-term basis, there is no significant improvement is there. In the similar way, 3 centers single-arm study by the Darjanelli, it also told that there is no superiority of the endovascular thrombectomy as compared to the medical management. So this is the overall study that compared endovascular thrombectomy versus best medical management. Best medical management included thrombolysis as well as other oral drug management, and that have told that in most of the studies they have told that
Dr. Shiv,
better medical management is not
regarding the time. The presentation slide 5 minutes have crossed.
Better medical management is not inferior to endovascular treatment. So why should I support mechanical thrombectomy in the low NIHS with large vessel occlusion? It is due to the long-term outcome is nearly same with increased morbidity risk in the mechanical thrombectomy trial. If the collaterals are good, we expect good recovery with mild symptoms, and there is more procedural complication and an anesthetic complication with the endovascular study that can be avoided by the medical management. So finally, till now, there is no definite randomized control trial with the last sample that has proved that endovascular thrombectomy is better. So there is no level 1 evidence. So we should better go for medical management as compared to the endovascular study. Thank you.
Okay, okay. Nice, Dr. Shiv and Dr. Akhil. I think now you have really created a debate situation in this low NIHS to intervene or not. So, Dr. Akhil, do you have any rebuttal?
Yes, sir. Yes, sir.
Yeah, so please start. Please convince your audience that you should intervene. Okay.
Yes, sir. Thank you, Dr. Shiv, for excellent lecture. Now, for the rebuttal, I will take point by point the points that have been presented by Dr. Shiv. But first, will again emphasize that in mild strokes, there is immediate progression because of infarct growth, as compared to delayed recurrence or death. So we have to intervene early. There is no point of waiting and seeing the outcome as 3 months or 4 months or 2 months, because the progression, immediate progression, will lead to early disability. And even if there is no death, but the patient with disability with such mild stroke, what will he do in life? So we have to intervene early. So there was some EVT trials also comparing the outcomes in high and low NIHS scores. So there was all of these were retrospective analysis. There was one retrospective analysis done in Netherlands from 2014 to 2016. That was done using the clinical registry of endovascular treatment of acute ischemic strokes that was stratified by NIHS less than 5 and NIHS more than 6. So in this study, we can see that there is a definite favorable outcome at 90 days. In the previous sir was saying, Dr. Shiv was saying that the 90-day outcome was not adequate as compared to in the thrombectomy arm as compared to the medical arm. But in this study, we can see that MRS 0 to 1, 0 to 2, and 0 to 3 at 90 days was significantly better, with significant p-value and even with confidence intervals in patients who had NIHS less than 5. And in these patients, there was no significant difference between symptomatic ICH bleeds. So the point that there is increased bleed can be negated by this retrospective study, and the point that there is no outcome at 90 days patients with thrombectomy can also be negated with this study. Now, now if you are doing best medical management, we can give TPA also. But now we have seen that there was a landmark paper in 2010 that was published in Stroke by Bhatia sir, that is showing that there is very less chances of recanalization with IV TPA as compared to endovascular treatment. Like we see in case of M1 MC strokes, 32.3% of the patients as compared to 43% of the patients are recanalized with IV TPA as compared to endovascular treatment. And there is a definite relationship of recanalization with good outcomes in form of MRS at 3 months. So those patients who are getting recanalized have a better outcome. And those patients who are not getting recanalized, even with TPA, and what can we say of best medical management, have a very poor outcome at 3 months. So we need to recanalize these patients immediately. And as far as safety of EVT is concerned, there has already been, EVT has already been studied in landmark 2015 5 trials, and Hermes meta-analysis was done. In this meta-analysis, we can see that symptomatic intracranial hemorrhage and paracameral hemorrhage type 2 is significantly less, and not significantly more as compared to control population in the patients who received endovascular therapy. And there is definite mortality benefit in these patients. So the point of safety can be negated by this trial only. But of course, we need a trial because we are having only retrospective studies of NIHS less than 6. We need a trial, but hypothesis says that if there is a benefit to the patient with poorer aspect and higher NIHS, there should be more chances of benefit to the patient with endovascular therapy in those patients who have a low NIHSS with large vessel obstruction. Now, some EVT feasibility trials were also conducted. That also stated, although it was a small study from 20 patients to 138 patients, most of these studies have shown that we can achieve a good TICI outcome, as well as the symptomatic ICH is approximately 3 to 5%, except one study that was conducted by Bogle et al. As we can previously see, here it was approximately 4.4 and 5.1 was the parenchymal hematoma. So it was approximately 5 and 3% outcome can be taken in the EVT trials. And because they are previously in the meta-analysis also, 5% of the patients had, approximately 5% of the patients had hemorrhagic transformation. But it didn't translate to mortality in those patients. So that is an important point. So we can, there were some EVT versus IVT trials. They were having, again, they were bounded or by low numbers of the patients. But in these studies also, we can see that there was no significant ICH as compared to the endovascular therapy as compared to the IV thrombolysis therapy. So we can see that EVT will be beneficial, and if it is found to be safe and effective in previous trials, and NNT of EVT is far, far better than intraventricular thrombolysis. Now we can see that in 2013, we were doing thrombectomies and all the trials were negative for thrombectomies. We never stopped doing that, but there was no randomized trial as we are searching for these. But then came 2015 and 18 and everything changed. So we are waiting for the randomized trial. There are a few randomized trials. They are ongoing, like endo, low in extremities and trimis. They are all phase 3 trials with recruitment of NIHSS scores of 0 to 5. So let's hope that these trials will give us a positive outcome, and from when the results come, we will, like previously after Dawn diffuse and after MR clean, extend IA trials, we are doing thrombectomies with much more confidence. Now after these trials, they can give us some answer, and we will do thrombectomies in these patients. So my take home message is that NIHSS is a poor predictor of outcome in mild strokes. And it is also a poor predictor for LVO in mild strokes. And early neurological deterioration is present significantly it varies from study to study. And approximately 50% of mild strokes can also present with early neurological deterioration with LVO. And EVT from previous trials has been found to be safe and efficacious. And in selected group of patients that I mentioned earlier, those patients who have a disability, those patients who have a fluctuating NIHSS, those patients who have a head-up test positive, like making the patient stand up for 10 minutes and his NIHSS worsens, that means his collaterals can fail anytime. And those patients who have a large perfusion deficit should be taken for a mechanical thrombectomy, although we need randomized trials to prove our point. Thank you so much. And I thank all my teachers, and I pay regards to all my teachers for giving me an opportunity to speak in this session. Thank you.
Good. And I think Dr. Shiv, your work is tough or easy. Let's see your rebuttal, and we will conclude after that. Dr. Shiv, you have any rebuttal?
Sir, are you able to see?
Yes, we can see it. It's audible.
Why mechanical thrombectomy should not be the choice in all acute large vessel stroke with low NIHSS? The first point is lack of solid evidence. Even though there are some trials which are telling that mechanical thrombectomy is much better as compared to best medical management or only thrombolysis, but there is no large randomized control trial that has been put till now. Even the American Health Association, ASA Association, that is not also supporting the thing. Only some retrospective multi-center studies are available, and there is also discrepancy in the final outcome. As like that, only one to two trials, those have told that symptomatic ICH is not that significant, but most of the trials, those have told that symptomatic ICH is much significant in the mechanical thrombectomy trial. There is some lacuna in the studies, those are supporting endovascular thrombectomy. In the House and et al., it has mentioned that NIHSS safety is much better in the endovascular thrombectomy trial as compared to the best medical management, but the sample size is very less. the only 10 thrombotomy patients have been taken into account, and 90 days MRS outcome is not so significant, and safety outcome as mortality is also not so significant. And they have also taken the orthostatic challenge. That means they have make patient 90-degree for 10 minutes, and that has also worsened the collateral perfusion, and that has also affected the result output. In the meta-analysis done by the Sang et al., even though they have told that mechanical thrombectomy is better, but they have more spontaneous ICH, more heterogeneity in the baseline status, and they have not mentioned collateral status in the detail. And also, it is not a non-randomized trial. So we cannot believe on a smaller amount of the patient taken into account and telling that mechanical thrombectomy is better, or best medical management is better. So we definitely need a last trial, randomized trial. Similarly, in the Helder et al. In 2020, it is a recent trial. It has compared primary endovascular thrombectomy versus intravascular thrombolysis versus conservative management and secondary reperfusion. But they have told that there is no major difference between the primary endovascular thrombectomy and the intravascular thrombolysis if it is done within 4.5 hours. And but in this trial, they have not mentioned vessel occlusion status, whether it is present in the M1 segment or M2 segment. They have not clearly mentioned in all those sample size, and there is definite higher motility on the endovascular thrombectomy. Similarly, other studies have also told that uh, thrombotomy, mechanical thrombotomy is much better as compared to thrombolysis. But in all those studies, they have not mentioned collateral status in all patients, and there is also some discrepancy about the excellent outcome, even though the functional outcome is statistically significant, but excellent outcome MRS 0 to 1 at the 90 days is not statistically significant. So on the basis of risk benefit analysis, there is more chance of ICH, more chance of asymptomatic ICH, and more chance of anesthesia and retrieval-related complication is there. So that is more supporting medical management as compared to mechanical thrombectomy in case of low NIHSS score. When if the collaterals are good, they can heal up itself. And the third point that most of the studies, they have not mentioned the baseline characteristic so matched study, because all those are single base or small sample size, and that has to be more focused question to be put for the further study, and randomized controlled trial has to be done before predicting that which one is better. Till now, I think best medical management is much better as compared to thrombotomy trial.
So any questions from the residents or anyone? Because this is still debatable, but we would have at least a conclusion that there is definitely no level 1 or high quality evidence to suggest that this should be our first line of management. But definitely we have learned from our past in cases with NIHS more than 6 that initial trials like MR rescue, IMS3 and synthesis, initially they failed. So probably a properly selected patient, and with, I would not suggest that this head up test, any test which can worsen the clinical situation, but at least selected patients of low NIHS with at least low blood pressure, which have been recommended, which have been seen to benefit, that patients with low blood pressure, patients with larger perfusion deficits and poor collateral status, those patients should be at least considered for mechanical thrombectomy, and also patients who have fluctuating course, or also who are having progressive course in that hyperacute or acute state. Additionally, we also observed that in this low NIHS cases, we ought to miss upon a point which Dr. Akhil had mentioned, that how best the NIHS scoring has been done. Because sometimes we do the NIHS scale and that itself has fallacies. It is 5 or 6 or 7. So sometimes you make it calculate it as 5 or 6 and you deny a treatment. So I think we have another point of considering the NIHS score, which is best possibly done, and then properly classify them into really low NIHS. So with this, I think we can conclude our session, but this is still debate is continued and we will wait for the randomized trials, but definitely with our previous experiences before this 2015 all randomized trials, there was issues with endovascular thrombectomies, but at least it is safe in these selective cases, and it should be again done in selective cases, but definitely it should not be a standard of care till we have level 1 evidence that we will continue doing thrombectomy in low NIHS cases, which is like for everyone, but it should be considered very much case to case basis that mechanical thrombectomy should be done. Otherwise, definitely best medical management with these retrospective studies which have been shown by Dr. Shiv, that best medical management is still better till we get any randomized trials. So with this, we will close it. If we have any questions, we can take. To the organizers, I think in chat box,
Yes,
there are
sir.
no questions. Do we have any questions or we conclude?
Dr. Deependra, are there any questions?
Once again, I think we can conclude here, sir. The debate we can conclude here, sir. And once again, good evening, everyone.
And I would
today we have gained
I would like to thank, before Dr. Deependra, I would like to thank again the organizers, and it was really wonderful experience. And I must congratulate Dr. Akhil and Dr. Shiv, those who worked for this debate. They have put their best efforts, and I must appreciate them again for their wonderful presentation. And it must have helped everyone, all the residents must have created at least thought to consider these treatment in the cases with low NIHS. Thank you. Thanks again to the organizers and course directors. Thank you.
Thank you, sir. As we know, today we have gained a plethora of practical and theoretical knowledge. Though many thought-provoking questions have been asked by the delegates, I shall be able to put forward only 1 or 2 questions, and due to paucity of time. So I'm going to ask 2 questions for Professor Khurana, sir. So the question is, can cerebral amyloid angiopathy leads to transient focal neurological episodes, sir? I think sir is not there, sir. Professor Bhatia, sir, can you take on this question, sir?
Yes, it can present, and that's a differential diagnosis of TIA as well, and could present. And I think Dheeraj has also answered it previously, if I'm not mistaken, and he had also talked about this, calling it amyloid spells as well. So yes, we can have patients who present with brief episodes, even in amyloid angiopathy.
Sir. One more question, sir. What is the role of genetics in understanding a small vessel disease where there are no clear risk factors, sir?
Okay, so is Dheeraj around? I mean, would he be there to answer? Not sure.
I think sir is not there, sir.
Okay. Yes, so most of the advances in understanding of the small vessel disease is mainly around the monogenic causes of vascular disease inheritance, especially the disorders like CADASIL, Fabry's, and others. We have some data to suggest that people who have sporadic small vessel disease diagnosed as sporadic small vessel disease, which is typically based on risk factors, age, pattern on imaging and presentation and follow-up and progression, there may be a subset of patients who may be diagnosed as sporadic small vessel, but actually may be having underlying genetic predisposition among the set of disorders which are very well known to be characterized by monogenic disorders. Unfortunately, we don't have large studies or large population-based studies to say that people who present with usual small vessel disease, what percentage of them would actually be having an underlying genetic cause. But I guess there are definitely such subset of patients, especially the ones who present with more aggressive small vessel disease, even though with risk factors, because we see this heterogeneity. We have people with uncontrolled diabetes, uncontrolled hypertension, but not all develop small vessel disease. And some of them develop large artery disease. Some of them develop a different pattern of angiopathy involving the retina or the renal system and so forth. So I guess I personally feel that within the whole process of small vessel disease, even in patients who have conventional risk factors, there would be a subset of patients where there would be a definite underlying genetic predisposition and genetic causes or genetic abnormalities which could be compounding the whole effect of their risk factors as well.
Thank you, sir. The answers for the rest of the questions will be mailed subsequently. And now I hand over to Dr. Snigdha for the further proceedings for the day.
Thank you, Dr. Deependra. Today's session has been an excellent informative session and a great start for our program. I would like to thank all the organizers, speakers, moderators, participants, and the delegates. We had a very great enlightening lectures and riveting case discussions and an absorbing debate. There's a small note for the debate participants. There is a prize for the debate participants, that is the Fundamentals of the Evidence-Based Medicine textbook by Professor Kameshwar Prasad sir. So with this, I would like to conclude today's session. And there is one more small request from the organizing committee, that is we shall try to stick to the timings of the lectures from tomorrow as per the schedule, as today we were actually crossing the time limit. Thank you. I would like to thank all the speakers, moderators, and organizers. Thank you.